Good evening to all. This is Dr.Ajaiy and now we will discuss about the ENT questions which were asked in last week AIIMS June 2020. So, in the previous video we were discussing about PGI questions and now we will discuss about the AIIMS questions. Usually in AIIMS question around 5 to 6 questions will be from ENT, and every year there will be some repeaters, as there has been 1 or 2 repeaters this year also, but the clinical scenario and the image based MCQs will be more of some a bit tough also. Okay. So, this year I hope compared to last year it was a bit easy, but in the ENT it seems to be a bit difficult with some retractors and with some image based MCQs. Okay. And but there were some repeaters, basic repeaters like a BPPV also, benign paroxysmal positional vertigo. So, we will go ahead with this topic, the questions. Okay. The first question, identify this was again an image based MCQ. Okay. Identify the given processes used in this post laryngectomy patient. So, here they are giving a post laryngectomy patient, and here there seems to be some processes sitting over here. Okay. So, what it could be? Again, this is a easy one, but if you would have come across this post laryngectomy or total laryngectomy chapter, then it is easy. If you do not know any idea about laryngectomy or the vocal rehabilitation, then it is bit difficult. Okay. So, the answer is this one is a tracheoesophageal prosthesis. I will explain it in next slide. Okay. This one is a tracheoesophageal prosthesis. So, what is a total laryngectomy? The total laryngectomy involves removal of the entire larynx. Okay. Up to the first trachea, the removal of the entire larynx starting from the epiglottis and even the part of the hyoid bone, the entire larynx is removed. So, now the vocal cords are removed. So, the patient's voice is gone, right. So, there will not be any voice with the patient. So, in this scenario you want to give the patient a voice rehabilitation to the patient. Okay. So, voice rehabilitation is required. So, what are the methods of voice rehabilitation following a total laryngectomy? Following a total laryngectomy, there are different methods of voice rehabilitation. Obviously, the patient does not have any vocal cord for his voice. Okay. So, there are different methods which have been tried. One is a either is a artificial larynx. Artificial larynx indicates the patient does not have larynx. Okay, we are artificially giving him some instrument that can replace the normal larynx. Okay, that is artificial larynx, and it is of two types. Either it can be a electrolarynx or it is a transoral pneumatic device. Okay. So, what I said, artificial larynx is a larynx, it is not a larynx, we are giving some device to replace the function of the larynx. Okay. So, what is electrolarynx? Electrolarynx is nothing but, say it is something like this handheld device. Okay. Now, the patient does not have any larynx, does not have any vocal cord to produce a sound. So, how the sound is produced? The sound occurs because of the vibrations of the vocal cord, the sound travels through the vocal cord, and it is being articulated from the tongue, lips, and from the pharynx, tongue and lips, it is being articulated. Now, the patient does not have a vocal cord. So, what we are giving is, we are giving this is a electrolarynx. Okay. Electrolarynx, in which the patient has been given a handheld device, and the patient is asked to keep the device exactly in the soft tissue area of the neck. Okay. And it is a vibrating device. Okay. Once it vibrates, what happens is it produces some air currents within because of the vibration in the soft tissue of the neck. Okay. And because of the vibrations, when the patient phonates, say this vibrations, when the patient phonates, because of the vibrations, the sound, the patient may able to produce some small monotonous sounds. Okay. That is called as artificial larynx, and this is the electrolarynx. Transoral pneumatic device is again a device which is given transorally. Here again it produces some vibrations through which the patient can produce a minimal sound through its talk. Okay. So, here there is no vocal cord, so the patient is a artificial production of sound. Clear. So, electrolarynx and the artificial larynx. So, the second one, The second one is esophageal speech. Esophageal speech. So, here now what we discussed in a total laryngectomy, the entire larynx is removed. Okay, so the patient does not have any vocal cord to produce a sound. So, he needs some other structure to produce a sound. So, here we can train the patient to speak through his esophagus. Okay, we can ask him to take some bouts of water. Okay, or we can ask him to take some bouts of, ask him to swallow repeatedly, swallow the air repeatedly, exactly it is swallowing the air repeatedly, okay, and ask him to keep in his food pipe, okay, and phonate it with it, okay, that is called as esophageal speech. This is done through a therapist, not the TC. This is the second method of voice reconstruction. And then the next method is, tracheoesophageal prosthesis, TEP. TEP stands for tracheoesophageal prosthesis. So, as the name indicates, following total laryngectomy, we are again creating a fistula between the trachea and the esophagus. Okay, and this fistula is being connected with a prosthesis. So, what is you may ask me, what is the link here? You are putting a permanent tracheostomy following a total laryngectomy, okay, and you are advising the patient some esophageal speech, okay, but what is the need of creating a fistula creating an opening between the trachea and esophagus? Won't it produce any regurgitation, or won't the saliva, or won't the secretions leak out through the trachea? Exactly, that is a complication, okay, but this prosthesis will prevent that complication. And what is the role of the tracheoesophageal prosthesis is, here we are artificially creating a fistula between the trachea and the esophagus. It is not a complication following total laryngectomy, we are artificially creating a fistula between the trachea and the esophagus, okay, and we are inserting a prosthesis here, okay, so that what happens is, whenever the patient tries to phonate, he can close that hole over the prosthesis, okay. Once he closes the hole over the prosthesis, that will produce a vibration of sound, that breath from the larynx goes, because of closure of the tracheostomy area, it goes through the tracheoesophageal prosthesis into the oral cavity, oropharynx, and it has been articulated with the tongue, lips and cheek, as I said previously, okay. This is the role of tracheoesophageal prosthesis, and there are various prostheses named as, one is duct-bill prosthesis, okay, duct-bill prosthesis. These are in market, these are processes, these are different types of processes, nothing else, okay. So, how it appears like, so here now coming on to the picture, here, okay, here I could see a permanent tracheostomy tube here, permanent end stoma tracheostomy here, there is a complete gap here, okay, and in between the gap there is some white prosthesis been attached over here. So, usually if this is the tracheostomy tube, this tracheoesophageal prosthesis will not completely close the tracheostomy side, it will be sitting at one superior end, okay, at one superior end it will be sitting, through that when the patient tries to phonate, he can just close the tracheostomy and he can phonate through it, that is a tracheoesophageal prosthesis. So, this one, the answer is tracheoesophageal prosthesis, and as I explained previously, there can be some complication of some leak of food particles through this trachea also, okay, that is one of the complication, but this is a artificial tracheoesophageal prosthesis, the answer is option C. So, coming on to the next one, yeah. So, question number 2, yeah, so nowadays AIIMS is also going more clinical oriented, okay, in the scenario of next, which is about to begin coming years, I hope all the CRRIs, all the upgoing past CRRIs who are appearing for exams, be practical, okay. The simple question, what they asked, identify the pyriform fossa, that is it. Okay, if we have attended our ENT clinical postings during our CRRI period, we will know it. So, where is the pyriform fossa? Simple. So, just imagine this picture. Okay. So, this is the picture which was about to be given. This is not the exact picture what they gave, this is the picture which was about to be given. So, this is a indirect laryngoscopic picture. Okay. Or sorry, this is a direct laryngoscopic picture. Okay. So, this one is a epiglottis, this one is epiglottis, and this one is a vocal cord. Okay. So, when you draw a vocal cord, say when I am drawing when I am drawing a vocal cord like this. Okay. So, this is anterior, this is posterior. What will be in the posterior end of the vocal cord? The arytenoid process, right. So, this one is a arytenoid process. Okay. So, what is this between the arytenoid and the epiglottis? This one is a airy epiglottic fold. Okay. So, if this is a true vocal cord, what is this area? This is a ventricles. Okay. So, and what I said, one is arytenoid, two is a vocal cord. Okay. So, fine, this is epiglottis, this is the area epiglottic fold. Okay. So, this area posteriorly. So, this area here there will be cricoid cartilage, here there will be cricoid cartilage. Okay. Just behind the area, this area will be a post cricoid area, and this gap in this area, that is number 3, indicates the pyriform fossa area. Okay. Pyriform fossa area, that is number 3. So, so one is, what is one? One is arytenoid, 2 is a true vocal cord, 3 is this pyriform fossa, 4 is marked somewhere between the between front of the epiglottis, that is in fact in the which area? That is in the vallecula area. Vallecula is a projection between the epiglottis and the part of the tongue. Okay, that is marked in the vallecula area. Okay. So, very simple MCQ, just we need to know what is what. If you know this, fine. So, this is a simple MCQ which no one will miss. The answer is option C or option 3. Okay. So, coming on to the next MCQ, again a repeated MCQ, a easiest MCQ. What I said, in a AIIMS there will be repeaters, in ENT purpose there will be some 2 or 3 repeaters, and the rest will be some thinking purpose, some recent advances which it's very difficult to answer, I accept that, but repeaters you should not miss it. Okay. So, the anterior most anterior ethmoidal cell. So, which is anterior most anterior ethmoidal cell? Yes. So, I hope around 90 out of 100 you would have got it right. Okay. The anterior most anterior ethmoidal cells, just have A for A. Okay. If you just confuse an exam, just have in mind A for A. Okay. A is what is the option A here? And again it's A is agar nasal cell. So, agar nasal cell. So, A is the first roll number, obviously I am Ajay. So, I am with the first roll number. So, A the first roll number or whatever you may think, the anterior most anterior ethmoidal cell, think of A for A, that is agar nasal cell. Okay. So, we will discuss about the other cells also. The agar nasal cell on a CT scan will appear like this, that is the anterior most anterior ethmoidal air cell. Okay. What is the significance of this agar nasal cell? It appears as a bulge. Where it appears as a bulge? In front of the middle turbinate. Okay. It appears as a bulge in front of the middle turbinate. What is the second significance? Say if this agar nasal cell is getting bigger and bigger. Okay. What is this one? This one is a frontal sinus, right. So, if this goes bigger and bigger, it blocks the drainage of frontal sinus if there is hyperpneumatization of agar nasal. So, hyperpneumatization of agar nasal causes blockage of frontal sinus drainage plug. Okay. So, these are the two significance in the Ajaiy cell. So, 3 important MCQ: Ajaiy cell, most anterior ethmoidal air cell, and it appears as a bulge in front of the middle turbinate, and if it is hyperpneumatized, okay, it may cause blockage of the frontal sinus drainage tract also. Okay. So, coming on to the next cell, what are the other options as Onodi cell, Haller cell, a very important MCQs, which was a last year MCQ in AIIMS, maybe the previous year also, and this year they have just changed the MCQ, that is it. Okay. So, what is Haller cell? So, what is Haller cell? Haller cell is a anterior ethmoidal cell. Anterior ethmoidal cell, remember, it is an anterior ethmoidal cell which occurs just below the orbit. Okay, just below the orbit. This point marked with the star is a Haller cell. What is the significance of Haller cell is during surgery if we pass our endoscope like this, okay, if we blindly injure this cell or if we try to remove the cell, we may injure the orbit. Okay. So, Haller cell is a anterior ethmoidal cell, lies in close contact with the orbit. Okay. So, going to the next cell, Onodi cell. Onodi cell, I will give a mnemonic, think of ON for optic nerve. Okay. Onodi cell is a posterior ethmoidal cell, this one is a Onodi cell. Okay. So, normally this is a sphenic sinus which has only 2 pneumatization, here there is an extra pneumatization, that is the Onodi cell or the posterior ethmoidal cell, and this is the optic nerve area. This one is here there will be optic nerve area. So, what has happened is this Onodi cell, okay, here it almost encompasses the optic nerve. Okay. So, what happens is this is a posterior ethmoidal cell, and during surgery if you are passing endoscope like this, I may damage the optic nerve. Okay. So, injury to optic nerve is more within Onodi cell. Okay. That is what I said, have a mnemonic of ON. Okay. Injury to optic nerve is more with the Onodi cell, that was a last year MCQ also. Okay. So, just have it in mind. So, Onodi cell and the Haller cell. Haller cell are anterior ethmoidal cell, Onodi cell is a posterior ethmoidal air cell, the anterior most is a Ajaiy cell. Bulla ethmoidalis is the Bulla ethmoidalis, which is the biggest ethmoidal air cell. Bulla is the most constant, okay, ethmoidal air cell, most constant, that is it is present in everyone. Okay. So, if you want to do ethmoidectomy, you want to break the bulla first. Okay. It is the most constant ethmoidal air cells and it is the most biggest also. Okay. So, coming on, so the answer is A for A, Ajaiy cell. So, coming on to the next MCQ. Okay. This was something tricky. Okay. They put a picture like this, it is not the exact picture, I am not sure this is the exact picture they asked. Okay. There was a picture which showed some injection or irrigation is given between the medial canthus area and the nose, around this area. Okay. Around this area, exactly. So, what could be the option? Option A or B or C or D. Okay. Again I am saying this is not the exact picture given, there was this just a recall from students, the picture was something between the medial canthus and the eye. Okay. So, can it be option A? Yes, we can keep it as option A since anterior ethmoidal nerve runs over this area. Okay. Can it be frontal sinus? Frontal sinus is here, maybe examiner's thumb is pointing towards the frontal sinus, but not the needle. Okay. So, we have to rule out the frontal sinus. Can it be median nerve? Median nerve never comes anteriorly, it never runs over the skin area, it runs behind it. Okay. So, you rule out the median nerve also. Can it be the syringing or the nasolacrimal duct probing? Obviously, it can be, since where is the nasolacrimal duct? This is the opening of the upper canthus, this is the lower canthus, and here I am going to between the medial canthus and the eye, I am going to put a lacrimal syringe and do a syringing. Okay. So, now my idea of option between A or D. Okay. This is a bit tricky again, okay, but I will go with D. Okay. Since it appears like there is a syringing being done in the canthus. okay, and this appears something like a lacrimal syringe, or this appears something like a syringe, and the probe usually if it between the medial canthus and the medial canthus of eye and the tip of the nose, think of a nasolacrimal duct probing. You may ask me why it is not an anterethmoidal nerve block. Yes, it can be anterethmoidal nerve block, but where is the structural anatomy of anterethmoidal nerve where the anesthetist will give a block is exactly not near the medial canthus, just below the medial canthus, in this area. When we go through the anatomy, okay, it is not in the medial canthus area, just beneath the medial canthus area, okay. Here there lies the anterior ethmoidal foramen, okay. It is not here, it should be somewhere below. So, when you want to, you can feel it in your nose also, okay. So, when you want to block the anterethmoidal nerve, it runs just below the medial canthus area. Once you put a injection or irrigation here, this part of the anterethmoidal nerve will get anesthetized, okay. So, if the injection is being given here, then I would go for option A, anterethmoidal nerve block. But here it is typically pointing that it is just exactly in the eye area, just exactly in the medial canthus area. That means I will go with option D, that is the nasolacrimal duct probing or a syringing, okay. So, coming on to the next one, again this is a bit difficult. I will not accept that this is easy, this is a bit difficult for a exam going student, okay. So, identify the instrument, maybe it is a repeater, but I will say that it is a bit difficult, okay. So, identify the instrument, okay. So, what it appears? It is a mastoid retractor. This everyone knows, this is a mastoid retractor. So, what are the types of mastoid retractor? I am not sure these were the options given, but I have just put on some extra names, so that I will explain about the mastoid retractor since it was asked, okay. So, these are the different types of mastoid retractor, option A or B or C or D, and the answer goes with option B, Perkins mastoid retractor, okay. Perkins mastoid retractor is nothing but, Perkins retractor is, say all the mastoid retractor will appear like this, there is no doubt in this, okay. It will be appear like something like a some U shaped one and a scissor kind of thing, okay. So, all will appear like this, okay, but in the Perkins retractor it is 1 cross 3, that is one end will be a long flanged end, okay, one end will be bigger, the other end will be a 3 tooth end, okay. One end will be a 1 tooth end which will be a long flanged kind of thing, the other end will be a 3 tooth end, okay. That is Perkins mastoid retractor. So, the answer for this is Perkins mastoid retractor, but ruling out other option I will post the other pictures also, okay. So, Mollison's mastoid retractor, Mollison's is nothing but, Mollison's is a 3 cross 4, okay. Everything, all mastoid retractor are used for harvesting temporalis fascia and used for retracting the mastoid. So, here it is 3 into 4, Mollison's is 3 into 4, here one end will be a 3 tooth end, other will be a 4 tooth end, okay, Mollison, okay. And the option B is a option D is a Plester mastoid retractor, again it appears similar to this, but it is almost a 3 cross Plester is 3 cross 3, but the one thing to differentiate is the middle end will be somewhat bigger. In a Perkins, the middle area will be somewhat bigger in Plesters, I am just confusing it. In Plesters it is 3 by 3, in Perkins it is 1 by 3, in Plesters it is 3 by 3, but the middle one will be bigger, okay. And coming on to the next one, this is a smaller one, this is if it is smaller like this with the 3 cross 3, consider that is a Jensen's retractor, okay. These are the various types of mastoid retractor. What they have asked is a Perkins retractor, but Mollison's is one thing which is commonly used, which is 3 cross 4. Perkins is a one end will be 3 and the other end will be a long flanged end. Jensen is a smaller one, okay. And Plester is just for ruling out the option, not much of important, it is 3 by 3, but one end will be a one tooth, the middle tooth will be somewhat bigger, Okay. So, coming on to the next MCQ, which is a easy and repeated MCQs. Okay. So, a 30-year-old patient, the patient had a vertigo, the patient was suspected of BPPV, ENT HOD came and he did a diagnostic procedure. I am not sure this was the question asked again. This is I hope this was a question asked. Okay, I am not sure whether it was, again I am getting confused. I am not sure whether the question asked a diagnostic or a therapeutic, but if this was a question, ENT HOD did a diagnostic procedure with the patient in lying position. He did a diagnostic procedure. What could be the test? Okay. So, what is BPPV? BPPV is benign paroxysmal positional vertigo. It is a positional vertigo, involvement of posterior semicircular canal, which is most common. Okay. And here we are doing two maneuvers. Okay. One is a diagnostic maneuvers. Okay. Just have in mind D for D. Okay. Diagnostic maneuver, it is Dix-Hallpike maneuver. Dix-Hallpike, nothing but here I am just holding the head of the patient and making him lie down on one side. Okay. And again I am doing it on the other side. Okay. And checking the nystagmus and checking the nystagmus, which side the patient is getting nystagmus more, that is Dix-Hallpike maneuver. Okay. So, this is a diagnostic maneuver. So, diagnostic maneuver is a Dix-Hallpike maneuver. Once you diagnose which side is involved, then you can proceed with the therapeutic maneuver. So, therapeutic maneuver is, so now you want to do a treatment. So, therapeutic maneuver is a Epley's repositioning maneuver. So, here we are repositioning the why there is BPPV? It is because of the degenerated macula, degenerated otoconial debris, which are just present in the macula, Okay. So, what our role is, we want to reposition the degenerated macula back into its normal position. Okay. So, the treatment is Epley's repositioning maneuver. Treatment. Epley's repositioning maneuver is not a diagnostic maneuver, it is a treatment maneuver. So, now come on to the question. Okay. So, here again he did a diagnostic procedure with the patient in lying position. Diagnostic procedure. So, what I said, D for D, think of Dix-Hallpike maneuver. Okay. So, fine. So, hope these are the 5 or 6 questions which are asked in AIIMS, and hope everyone has done a bit well this year AIIMS, and all the best for your upcoming exams. Like maybe this Sunday you are getting a JIPMER exam. So, all the best for your JIPMER exams, and in case if you have any queries or if you have any doubts with this questions or any other doubts regarding ENT, you can just WhatsApp me in this number, this is my contact number, or you can just mail me ajaymuthu@yahoo.co.in, or for getting instant reply you better WhatsApp me, or in FB, Facebook or Telegram you can search for Dr. Ajaiy Exploring ENT. Okay. Any comments you can just comment in the YouTube section also, or you can comment in my WhatsApp or Facebook page also. Hope it will be helpful for your exam, and all the best for your upcoming exam. Thank you.